Maternal antibiotics. A 7-day course of parental and oral maternal antibiotics are usually prescribed for preterm premature membrane rupture because of the increased likelihood that an infection caused or further complicated the rupture for both mother and fetus or newborn. Antibiotics may stop the infection that caused or will occur with the rupture, thereby delaying the onset of labor and allowing the fetus to mature. Drugs to stop infection if early membrane rupture occurs usually include ampicillin, amoxicillin, and erythromycin. Drugs effective against GBS are common. Guidelines for specific drugs to correct infection associated with early membrane rupture may vary with culture and sensitivity test results, other maternal laboratory results, or changes in the drugs most currently recommended for this purpose. Nursing considerations. The woman may remain hospitalized until birth, or she may return home after a few days of hospital observation. If she is hospitalized, the nurse observes for signs of infection. Preparation for home management includes teaching the woman the following: avoid sexual intercourse, orgasm, or inserting of anything into the vagina, which increases the risk for infection caused by ascending organisms and can stimulate contractions. Avoid breast stimulation if the gestation is preterm, because it may cause release of oxytocin from the posterior pituitary and thus stimulate contractions. Take your temperature at least 4 times a day, reporting any temperature of more than 37.8 Celsius, 100 degrees Fahrenheit. Maintain any activity restrictions. Note and report uterine contractions or a foul odor to vaginal drainage. Preterm labor. In 2015, the preterm birth rate in the United States was 9.6%, down from a high of 12.8% in 2006. Preterm labor begins after the 20th week, but before the start of the 37th week of pregnancy. The physical risks to the mother are no greater than labor at term, unless complications such as infection, hemorrhage, or the need for a cesarean delivery also exist. Preterm labor, however, may result in the birth of an infant who is ill-equipped for extrauterine life, particularly if earlier than 32 weeks of gestation. Adverse effects of prematurity may include cerebral palsy, developmental delay, and vision and hearing impairment. Families may suffer heavy emotional and economic burdens. There is a significant disparity in the preterm birth rate between races in the United States. Non-Hispanic Black mothers had the highest rate of preterm births, followed by Native American, Hispanic, and white mothers. Asian mothers had the lowest rate. Many possible risk factors exist that might trigger preterm birth. A woman who has previously delivered a preterm infant is more likely to have preterm labor. Having a multifetal pregnancy or use of assisted reproductive technology carries higher risks for both mothers and their infants, such as cesarean births, prematurity, and infant disability or death. Smoking of cigarettes, when combined with smoking of marijuana, has an 85% increased risk for delivering preterm. Infants born at early term, 37 and 07 weeks of gestation, to 38 and 67 weeks of gestation, have an increased risk for poor outcomes in both the immediate and longer term period. The Association of Women's Health Obstetric and Neonatal Nurses, AHWAN, has launched an online campaign to promote the benefits of term pregnancy to women. www.gothefull40.com. Associated factors. Just as all causes of onset of labor at term are not known, the causes of preterm labor are also not fully known. Over half of the women who have preterm labor and birth do not have known risk factors. Other women who have many risk factors deliver at term. Preterm labor is thought to be initiated by multiple factors, including infection or inflammation, uteroplacental ischemia or hemorrhage, abruption or previa, uterine overdistension as with multiple gestations, stress, and other immunologically mediated processes. Some of the possible causes of preterm labor are the following: Maternal medical conditions, including infections of the urinary tract, reproductive organs or systemic organs, dental disorders, periodontal disease, pre-existing or gestational diabetes, connective tissue disorders, chronic hypertension, and drug abuse. Conceptions enhanced by assisted reproductive technology, including conceptions resulting in a single fetal gestation rather than a multifetal gestation. Present and past obstetric conditions such as short cervical length, 25 millimeters or less, multifetal gestation, preterm membrane rupture, preeclampsia, and bleeding disorders that involve the woman, fetus, or placental implantation area. Fetal conditions such as growth restriction, inadequate amniotic fluid volume, chromosome abnormalities, and other birth defects. Social and environmental factors such as inadequate or absent prenatal or dental care, maternal domestic violence episodes, maternal smoking and housing deficiencies such as homelessness. Demographic factors such as race and ages of the parents, financial stability, and the number of birth intervals of the woman's other children. Signs and symptoms. Signs and symptoms of early preterm labor are more subtle than those of labor at term and often occur in normal pregnancies as well. Prenatal visits and routine ultrasounds may reveal evidence of cervical changes that have been occurring over several weeks during the second and third trimesters. The woman may be only vaguely aware that something seems different, or she may not detect that anything is amiss. Only when preterm labor reaches the active phase is it likely to have characteristics typical of term labor. Symptoms vary among women, but common ones are as follows. Uterine contractions that may or may not be painful. The woman may not feel contractions at all. A sensation that the baby is frequently balling up. Cramps similar to menstrual cramps. Constant low backache. Irregular or intermittent low back pain. Sensation of pelvic pressure or a feeling that the baby is pushing down. Pain, discomfort, or pressure in the vagina or thighs. Change or increase in vaginal discharge. Increased watery spotting, bleeding. Abdominal cramps with or without diarrhea. A sense of just feeling bad or coming down with something. Preventing preterm birth. Community education. Preterm birth can impose substantial physical, emotional, and financial burdens on the child, family, and society. Ideally, nursing strategies to prevent preterm birth begin before conception with community education. Topics may include the following: role of early and regular prenatal care, including dental care, in preventing preterm birth. Duration of normal pregnancy. Consequences of preterm birth. Conditions that increase risk for preterm birth. Signs and symptoms of preterm labor. Consequences of preterm birth for mother, baby, and family members. Women who are aware of the consequences of preterm birth may be more likely to take action to prevent it. If they recognize that they have risk factors, they may seek prenatal care earlier in pregnancy. Recognizing that onset of labor in early gestation has subtle signs and symptoms compared with labor near term makes the woman aware that she should seek care promptly rather than waiting for more definite signs of labor. During pregnancy. During pregnancy, measures to prevent preterm birth include the following: reducing barriers and improving access to early prenatal care for all women, assessing for risk factors to permit changes if possible, promoting adequate nutrition, promoting cessation of the use of tobacco and recreational drugs, teaching women and their partners about the subtle signs and symptoms of preterm labor and ways in which they differ from normal pregnancy changes. Empowering women and their partners to take an active approach in seeking care if they have signs and symptoms of preterm labor. Improving access to care. Improving access to prenatal care should be customized for the community. What works in one area may be inappropriate for another. Difficult access is a serious problem for women who rely on public clinics for their care. Long waits, fragmented care, language barriers, and insensitivity of caregivers discourage women from obtaining care. Expanding the number of caregivers by using advanced practice nurses such as certified nurse midwives and nurse practitioners can reduce waits for care significantly. Nurses can help coordinate various aspects of care to limit the number of different appointments a woman needs to obtain complete care. Identifying risk factors. Identification of risk factors may allow reduction or elimination of these factors. Women should be rescreened regularly to identify new risks that emerge as pregnancy progresses. Women with high risk factors benefit from care such as more frequent prenatal care appointments, reinforcement of the symptoms of preterm labor, telephone contacts, and added assessments of fetal growth and health. Some risk factors can be reduced or eliminated if the woman changes her lifestyle. Many pregnant women stop smoking or using non-therapeutic drugs, changes that may be difficult for them to benefit their babies. A woman may need to rest more or stop working, which may be difficult or impossible for many. Nurses and social workers can help the woman reduce her risks as much as possible by helping her identify sources of support. Infections of the urinary and reproductive tracts are associated with PPROM and preterm labor. Screening at the appropriate times for pathogenic organisms in the urine, vagina, and cervix identifies women who may benefit from antibiotic therapy. Promoting adequate nutrition. An adequate maternal diet contributes positively to the length of gestation and the infant's birth weight. The mother's height should be measured at the first prenatal visit, and her weight should be taken at each visit to evaluate adequacy of weight gain. Every pregnant woman should be offered culturally sensitive dietary counseling. The Special Supplemental Nutrition Program for Women, Infants, and Children, WIC, is available to supplement the diet of some women from low-income groups. Anemia can be corrected with appropriate supplements. Women carrying more than one fetus need additional food intake. Educating women and their partners about preterm labor. All pregnant women and their partners should be taught about symptoms of preterm labor. Because half of preterm births occur in women with no identified risk factors, interpreters who are culturally acceptable to the woman and printed materials in her primary language should be used. Diagrams should supplement the words of any language for women of limited reading skills. Respecting cultural norms of the woman and her family is an essential part of prenatal care that encourages her to maintain care to identify possible problems early. Information about the vague signs and symptoms of early preterm labor should be reinforced regularly as part of prenatal care. Women who often have uterine irritability may be given guidelines to observe at home before they should go to the hospital. Preterm labor often has vague sensations to the woman, so any home care guidelines are individualized according to the woman's risk for a preterm birth, the gestation and prenatal status, and the likelihood that specific interventions are beneficial to mother and baby. In addition, women are taught to enter the hospital for evaluation if they are not sure about the seriousness of their sensations. Examples of home care guidelines include the following. Drink an adequate amount of water to improve hydration or reduce bladder irritation that may accompany a urinary tract infection, UTI. Empty the bladder frequently because a full bladder may be associated with uterine irritability and contractions. Rest in the side-lying position to promote uterine blood flow. Limiting physical activity may increase diuresis. Prolonged limitation of physical activity is not usually beneficial or safe for prevention of premature labor, although it may be required for serious maternal disorders such as cardiac disease. Palpate contractions for 1 hour or as instructed. However, notify the birth attendant or go directly to the labor unit for assessment if contractions increase in frequency, duration, or sensitivity. The nurse should verify the woman's understanding by seeking feedback such as having her restate the signs and symptoms of preterm labor and the appropriate responses to them. Empowering women and their partners. Delaying birth depends critically on early identification of preterm labor. Women should be encouraged to seek treatment promptly if they suspect preterm labor. The woman must communicate her concerns clearly when she arrives at the clinic or hospital. She should tell the triage person that she should be checked for labor, regardless of the subtlety of the symptoms. Caregivers should not make the woman feel foolish if she reports signs and symptoms that could be preterm labor, but turn out to be a false alarm. Otherwise, she may not seek care for recurrent episodes when she truly is in labor, and the opportunity to delay preterm birth may be lost. The nurse might suggest that a woman who is seeking care for possible preterm labor say, "I'm not due for 8 more weeks, but I think I may be in labor. I need to be seen right away, or I might have a premature baby." Therapeutic management. Management focuses on identifying those at risk for preterm birth, identifying preterm labor early and delaying birth if possible. If preterm birth is likely, the emphasis is accelerating fetal lung maturity and providing neonatal neuroprotection. Predicting preterm birth. Onset of changes that lead to preterm labor and birth may be subtle. The woman may not perceive any changes in her pregnancy. Research has focused on predicting which women will deliver early. Better identification of these women would allow more intensive treatment, ideally before preterm labor or rupture of membranes occurs. Also, many signs and symptoms of preterm labor occur in women who deliver at term, possibly exposing them to unneeded treatment. The key is to identify which women are really at risk for preterm birth and treat those women intensively while continuing regular prenatal care for women who are not truly at risk. A good screening test would provide quick results and would be inexpensive, usable for all pregnant women, non-invasive, and highly specific for predicting preterm birth. No screening test meeting these criteria is currently available. For these reasons, many evaluations may be used in an attempt to determine the best medical management for a woman. Cervical length. A short cervix, 25 millimeters or less, measured by transvaginal ultrasound at 22 to 24 weeks gestation, is associated with an increase in preterm birth. Although the pathologic process is not clearly understood, current evidence suggests that it is not a weakness in cervical resistance to uterine contractions. An updated meta-analysis and systematic review following and including the Optimum study showed evidence that vaginal progesterone reduces the risk for both preterm birth and neonatal morbidity and mortality when studying women with a singleton gestation and a mid-trimester cervical length of 25 millimeters or less without negative effects on neurodevelopmental outcome. The study recommends that universal transvaginal cervical length screening be done at 18 to 24 weeks of gestation in women with a singleton gestation and vaginal progesterone offered to those with a cervical length 25 millimeters or less. However, ACOG cautions that the predictive value of a short cervix as the only indicator of preterm labor is limited and recommends against its exclusive use to direct management of women with symptoms of preterm labor. Preterm premature rupture of membranes in a previous birth. Some women may have a predisposition to weak amniotic membrane structure that predates the actual leaking of fluid. This predisposition seems to repeat in subsequent pregnancies. Fetal fibronectin. Fetal fibronectin, FFN, is a protein present in the layers of the amniotic membrane. It is normally found in cervical and vaginal secretions until 16 to 20 weeks of gestation and again at or near term. If it appears too early, it suggests that labor may begin early, similar to the way elevated cardiac enzymes rise in the person experiencing a myocardial infarction. Maternal or fetal infections may be present if the FFN is positive during mid-pregnancy. Cervical examination, recent sexual intercourse, and vaginal bleeding can result in a false positive test when preterm labor is not truly present. To reduce false positive results, the test specimen should be collected at least 24 hours after significant vaginal manipulation from examination. Some research indicates that the FFN test has a high degree of negative predictive value, with a negative result indicating there is less than 1% chance of delivery in the next 2 weeks. Positive predictive value, indicating the patient will deliver in the next 2 weeks, is much lower at 12 to 17%. However, because these findings have not been supported by randomized clinical trials and due to the low positive predictive value of the test, ACOG does not support the exclusive use of FFN to direct the medical management of a woman with preterm contractions. Infections. Infections often increase the risk for preterm membrane rupture or birth, even if the woman does not initially have clinical signs or symptoms with the preterm labor. A UTI is common with preterm labor, so catheterized or midstream urine is often obtained for urinalysis and for culture and sensitivity training. Tests for other infections associated with increased risk for preterm birth include those that often are found if membranes rupture prematurely. A woman with an infection that is not related to pregnancy may seek care. Relevant testing may relate to acute gastrointestinal or respiratory tract infections that affect pregnant women as well as other people of both genders. More serious maternal infections may require cultures of maternal blood or respiratory tract or other secretions to determine the ideal treatment. Maternal pneumonia, although rare during pregnancy, increases the risk for fetal or maternal death as well as increasing the risk that a woman will give birth to a living preterm infant. Other poor health conditions during pregnancy, such as crowded living conditions or a chronic medical condition such as asthma, may increase a woman's risk for pneumonia as well. Identifying preterm labor. The reason to predict risk for preterm birth or to identify preterm labor early is to delay birth, thereby promoting further fetal maturation. Frequent prenatal visits. Women at risk for preterm labor should have more frequent prenatal visits. In addition to normal prenatal care, they are evaluated for evidence of preterm labor and their ability to follow preventive therapy. They should be assessed for development of new risk factors with each visit. Gentle cervical examinations, possibly with sterile speculum, are done if indicated by other signs or symptoms. A transvaginal ultrasound examination may identify the shortened, thinned cervix that often precedes onset of labor in the asymptomatic woman. Infections of any kind should be identified and treated promptly before rupture of membranes or onset of labor occurs. Stopping preterm labor. Once a diagnosis of preterm labor is made, management focuses on stopping uterine activity. Preterm delivery may be inevitable, but steroid therapy promotes earlier fetal lung maturation, particularly for very early gestations, such as 25 weeks. Treatment may add enough time for the steroids to be effective. Even one more day of fetal maturation may make a great difference in the outcome for the very premature infant. Initial measures. The physician initially determines whether any maternal or fetal problems exist that contraindicate continuing the pregnancy. Some examples are maternal complications such as hypertension or hypotension, hypovolemia, hypoxemia, cardiac disease, and pyelonephritis. Fetal problems needing prompt delivery may be demonstrated by persistent abnormal FHR patterns. Initial measures to stop preterm labor include identifying and treating infections, identifying other causes of preterm labor that may be treatable, and reducing activity. Identifying and treating infections. Infection, both systemic and local, has a strong association with preterm birth and premature rupture of the membranes. However, it may be unclear whether various microorganisms found at diagnosis of preterm labor are significant if the membranes remain intact. Blood studies identify signs of infection and also conditions such as anemia that are associated with preterm labor or affect its management. Common studies include a complete blood cell count with differential white blood cell analysis and culture for GBS, chlamydia, gonorrhea, or other suspected infections. Amniocentesis, transabdominal puncture of amniotic sac, may be done to obtain amniotic fluid for culture if III is suspected, because this infection would contraindicate stopping preterm labor. Fetal lung maturity testing will likely be done on an amniotic fluid specimen as well. Urinalysis with culture and sensitivity testing may be performed to determine whether treatment for a UTI is indicated. Culture results require a minimum of 24 to 48 hours to complete. Therefore, antibiotics that are effective against probable organisms are started as soon as the specimen is obtained. The medication can be changed if culture results indicate that a different antibiotic would be more effective. Prompt treatment of acute infections, such as pyelonephritis, improves maternal and fetal outcomes. Broad-spectrum antibiotics, e.g. ampicillin, penicillin, and an amnioglycoside, e.g. gentamicin, which are effective against many organisms, may be ordered. Medications such as clindamycin or metronidazole may be prescribed for a woman who requires a cesarean birth and is at risk for infection from anaerobic organisms. Identifying other causes for preterm contractions. The woman with polyhydramnios, identified by ultrasonography, may have preterm contractions because her uterus is stretched more than usual. Therapeutic amniocentesis to remove some amniotic fluid can reduce uterine irritability. Multifetal gestations also can be identified by ultrasonography if not previously diagnosed. These mothers may benefit from improved nutrition, stress reduction, assistance with household care, and other interventions. Limiting activity. Activity limits, usually by relaxing in the side lying or semi sitting position, increase placental blood flow and reduce fetal pressure on the cervix. However, lengthy and substantial activity restriction, e.g., complete bed rest, has not been shown to significantly prolong pregnancy. As in other individuals, activity restriction is associated with serious maternal side effects, some of which develop within as little as 24 hours. Adverse effects of substantial activity restriction during pregnancy may include the following: muscle weakness, including aching, muscle atrophy, and bone loss; diuresis, as the body tries to reduce the normally higher fluid level of pregnancy; poor nutrition as a result of appetite loss, lower food intake, and increased indigestion; weight loss or inadequate weight gain; orthostatic hypotension caused by the change in blood pressure regulation by baroreceptors; psychological effects such as increased stress about separation from her family, anxiety about the pregnancy's outcome, boredom from a decreased activity level and reduced contact with other people, and concerns about finances if her income is essential to her family. Sleep changes as depression increases or usual activities that direct her sleep-wake cycle are not present. Because of the adverse effects and lack of benefits for most women, bed rest is no longer routine. If necessary, individualized activity reductions may be prescribed. Changes may be relatively simple, such as change in work hours or duties, or finding ways to help the woman meet the needs for her other children, for example, transportation to school or other activities. Several rest periods during the day may be prescribed. Positions for rest may include the semi-sitting position with the feet and legs elevated. If lying down for a rest, a mother's frequent change of the side-lying position reduces discomfort from the pressure of remaining on one side for a prolonged time. Frequent position changes are also beneficial to women who require a hospitalization for their preterm labor. Women hospitalized for care of preterm labor may have a greater activity restriction. Ambulating to the bathroom may be limited because of maternal sedative effects from medications. If preterm labor stops, the woman may usually walk to the restroom for showers, voiding, and bowel movements. If she remains hospitalized for longer-term care, she may have activity orders that include sitting in a chair periodically or taking occasional short trips to another area in a wheelchair that her family or friends push. Whether the woman is expected to be hospitalized briefly or for a longer time, the following services may improve her adherence to care measures: physical therapy to help maintain muscle strength and coordination and to reduce muscle aching, fatigue, and bone loss; recreational therapy to identify appropriate activities to relieve boredom; occupational therapy to help the woman cope physically with lifestyle changes, particularly if discharge home is anticipated; complementary therapy to reduce stressors and enhance physical care measures; social work to identify how needs such as financial and childcare can be met; consultation with a psychologist to help the woman and family cope with added stressors. Hydrating the woman. Hydration to stop preterm contractions has not been shown to be beneficial for all women. High volume IV infusions may cause maternal respiratory distress if tocolytic medications are also administered, especially if given in combination with steroids. However, dehydration may contribute to uterine irritability for some women. This is often the case in those who have had an infection, such as an acute gastrointestinal infection, in which loss of fluid through diarrhea may exceed the nauseated woman's ability to drink water or other fluids. Infections with maternal fever, temperature of 38 Celsius, 100.4 Fahrenheit or greater, increase the patient's metabolic rate and may result in dehydration. IV fluids are ordered according to their expected benefit. Oral fluids are usually encouraged because hydration may reduce uterine irritability and the risk for UTIs. Tocolytics. Tocolytic medications have not demonstrated a decrease in the rate of preterm birth. However, they may successfully delay the birth of a preterm infant. Delay of preterm birth with tocolysis may provide time for the following: to give maternal corticosteroids to reduce respiratory distress in the newborn, to give antibiotics to prevent neonatal infection with GBS, to transfer the mother to a facility with a neonatal intensive care unit (NICU) that is appropriate for the gestation of her fetus at the time of birth, to give magnesium sulfate for neuroprotection of a fetus less than 32 weeks gestation. Tocolysis is considered appropriate for women 24 to 34 weeks gestation with regular uterine contractions and cervical change. Because tocolytic drugs have significant side effects, the decision about whether to treat for preterm labor is individualized based on risk factors, cervical dilation, and other signs and symptoms. EFM helps identify uterine contractions or irritability and establish fetal status. An FFN test may be done to determine whether the woman is likely to be in preterm labor. Ultrasound imaging provides information that may be useful to determine fetal age, adequacy of placental supply, and status of the cervix. Tests for infection are done if indicated. Current tocolytic drugs are used primarily for conditions other than preterm labor and therefore have effects on body systems other than the reproductive system. Risks and possible benefits of the drug chosen should be considered and communicated clearly to the woman. The lowest possible dose that inhibits contractions is used. 4 types of drugs are used for tocolysis. 1. Magnesium sulfate. 2. Calcium antagonists. 3. Prostaglandin synthesis inhibitors. And 4. Beta-adrenergics. Magnesium sulfate. Magnesium sulfate is used in management of pregnancy-associated hypertension to prevent seizures. Because of its added effect on smooth muscle relaxation, including quieting uterine activity, it may be used to inhibit preterm labor. Magnesium sulfate therapy has a well-established record of safety during pregnancy. When given to suppress preterm labor, magnesium sulfate has side effects, such as lethargy and sedation, similar to those seen in its use to prevent seizures related to hypertension. The ACOG Practice Bulletin 171, Management of Preterm Labor, supports use of magnesium sulfate as a short-acting tocolytic to provide for steroid therapy and for neonatal neuroprotection. Long-term therapy is not supported. Common hospital criteria for MAG sulfate therapy include the following: urine output of at least 30 milliliters per hour, presence of deep tendon reflexes, at least 12 breaths per minute. In addition, the nurse should assess heart and lung sounds with vital signs because fluid overload and electrolyte imbalances can lead to pulmonary edema or cardiac dysrhythmias. Oxygen saturations are often included with vital signs and other assessments. Bowel sounds are checked when therapy begins and every 4 to 8 hours because the smooth muscle in the intestinal tract may be relaxed just as the uterus is relaxed. Serum magnesium level measurements guide maintenance of therapeutic levels, 4.5 to 8.0 milligrams per deciliter. EFM identifies fetal drug effects such as reduced variability. Calcium gluconate, 10%, should be available to reverse magnesium toxicity and prevent respiratory arrest, which can occur if serum levels rise above 12 milligrams per deciliter. Excess serum levels of magnesium are less likely when the drug is given for preterm labor compared to when it is given for preeclampsia, because the renal function of the woman in preterm labor is usually normal. However, the nurse should remain alert for this complication of magnesium sulfate therapy. Calcium antagonists. Nifedipine, Adalat, Procardia, is a calcium channel blocker usually given for hypertension. Calcium is essential for muscle contraction in smooth muscles such as the uterus, so blocking calcium reduces the muscular contraction. Flushing of the skin, headache, and a transient increase in the maternal and FHR are common side effects. Headache generally resolves in 48 hours. Because nifedipine is a vasodilator, the woman may have postural hypotension. The nurse should observe for side effects of nifedipine and report a maternal pulse rate greater than 120 bpm. The woman should be given information about possible dizziness or faintness with nifedipine's hypotensive effects. She should sit or stand slowly and call for assistance if needed. Serial blood pressure should be assessed for evaluation of dosage changes. Prostaglandin synthesis inhibitors. Because prostaglandins stimulate uterine contractions, drugs can be used to inhibit their synthesis. Indomethacin, indocin, and ibuprofen are the prostaglandin synthesis inhibitors most often used for tocolysis. Maternal side effects are minimal because of the brief duration of therapy. Gastrointestinal side effects are usually limited to nausea, vomiting, and heartburn. The nurse should observe the woman for gastrointestinal side effects. Because indomethacin and ibuprofen can prolong bleeding time, the nurse observes for abnormal bleeding, such as prolonged bleeding after injections and bruising with no apparent cause. The anti-inflammatory effect of these medications can mask infection. Fetal adverse effects are more serious and may include constriction of the ductus arteriosus, pulmonary hypertension, and oligohydramnios. The ductus arteriosus should remain open before birth and will functionally close 12 to 48 hours after birth. Fetal adverse effects of prostaglandin synthesis inhibitors are unlikely if treatment is no longer than 48 to 72 hours and the gestation is less than 32 weeks. Amniotic fluid levels should be monitored and the drug stopped if volume is trending downward. The amniotic fluid volume usually returns to its previous level when treatment is discontinued. Regular ultrasound examinations and fetal echocardiography help determine whether the medication is having adverse effects on the fetus. Decreased fetal movements and absent FHR accelerations with fetal movement may occur if the fetal condition deteriorates. After birth, assessment of the infant may be performed for other complications such as pulmonary hypertension or intracranial hemorrhage, depending on the duration of treatment and the infant's gestation. Beta-adrenergic drugs. Ridodrine, Yatupar, was once the only beta-adrenergic medication approved by the U.S. Food and Drug Administration for tocolysis. However, it has been discontinued in the United States because of significant side effects, costs, and minimal increase in the length of pregnancy. Terbutaline, brethine, a bronchodilator, is the most frequently used beta-adrenergic for treatment of preterm labor. It is used to delay preterm birth to allow administration of corticosteroids and antibiotics, approximately 48 hours. The main side effects for beta-adrenergic drugs, including terbutaline, involve the cardiorespiratory system. Maternal and fetal tachycardia are common. Propranolol, Inderal, an agent that blocks beta-adrenergic drugs, should be available to reverse severe adverse effects. Because of reported cardiovascular events, terbutaline now carries a boxed warning and contraindications, black box, against prolonged parenteral use for more than 48 to 72 hours, for use of oral terbutaline for treatment of preterm labor, or to prevent recurrence of preterm labor. The nurse should assess a woman's apical heart rate and lung sounds before administering each intermittent dose of terbutaline. A maternal heart rate over 120 bpm or respiratory findings such as wet lung sounds or tachypnea, possibly accompanied by shortness of breath, suggest drug toxicity and may be a reason to discontinue terbutaline. Abnormal maternal and fetal assessments should be promptly reported to the physician. Accelerating fetal lung maturity. ACOG recommends administration of a single course of corticosteroids to pregnant women, 24 to 34 weeks gestation, who are at risk of preterm birth within 7 days. It may be administered as early as 23 weeks gestation, based on the family's decisions regarding resuscitation of an extremely preterm newborn. Administration of a single course may also be considered for a woman at risk of preterm birth within 7 days who is between 34 and 37 weeks gestation. Steroid therapy may reduce the incidence and severity of RDS and intraventricular hemorrhage in the preterm infant. Betamethasone, celestone, or dexamethasone, decadron, may be used for this purpose. Corticosteroids are indicated if the gestation period is between 24 and 34 weeks because of the high incidence of problems such as RDS that affect an infant born at this gestation. Delay of preterm birth for at least 24 hours after initiation of corticosteroid therapy provides the greatest benefit in reducing the incidence and severity of RDS associated with prematurity. Thus, one indication for tocolytic therapy is to delay preterm birth to allow the fetus to receive the benefits of the corticosteroid. Evidence shows that an infant born sooner than 24 hours after administration of corticosteroid may have some fetal lung maturation benefits. Therefore, concerns regarding the probability of delaying the birth should not prevent administration of corticosteroids. Vital signs should be assessed to identify fever and elevated pulse rate that may indicate infection. Lung sounds should be assessed with vital signs because corticosteroids can cause sodium retention with accompanying fluid retention and pulmonary edema. The nurse should observe for symptoms of pulmonary edema. The woman is taught to report any chest pain or heaviness or any difficulty breathing because these symptoms could indicate pulmonary edema. Neuroprotection. Neonatal complications of preterm birth include neurological problems such as cerebral palsy. Current evidence supports the administration of magnesium sulfate to the mother before birth to decrease the risk. The ACOG and the Society for Maternal Fetal Medicine recommend its use for women at less than 32 weeks gestation and with anticipated preterm birth. Protocols for the administration of magnesium sulfate for fetal neuroprotection are similar to protocols for its use in preeclampsia or as a tocolytic agent. Periviable birth. The ACOG and SMFM Obstetric Care Consensus No. 4 addresses periviable birth, which is defined as birth at 20 and 0.7 weeks to 25 and 6.7 weeks gestation. Prenatal and postnatal counseling regarding the anticipated neonatal outcome based on the specific circumstances of each patient should be provided. If the family desires resuscitative efforts of a periviable neonate, management strategies may include short-term tocolytic therapy to allow time for administration of antenatal steroids, antibiotics to prolong latency after preterm premature rupture of membranes, or for intrapartum group B streptococci prophylaxis, and delivery, including cesarean delivery, for concern regarding fetal well-being or fetal malpresentation. If birth of a periviable neonate is anticipated, administration of magnesium sulfate for fetal neuroprotection is supported. It is recommended that periviable births occur in hospitals with expertise and support services for high-risk maternal and neonatal care. Application of the nursing process. Preterm labor. Nursing care for the woman experiencing preterm labor often includes interventions related to tocolytic, corticosteroid, or antibiotic drug therapy. If labor cannot be halted, care is similar to that for other laboring women, with additional care to prepare for a preterm infant's needs at birth. Support for anticipatory grieving may be needed if the infant is very immature and not expected to live. Care for the family when an extremely preterm infant, about 20 through 24 weeks of gestation, is expected to be born can be heavily laden with ethical and legal issues. For example, what is the true accuracy of the gestational age? Has a corticosteroid to accelerate fetal lung maturity been administered? Has magnesium sulfate been administered for neuroprotection? If labor cannot be halted, is fetal monitoring beneficial? Abnormal fetal monitoring patterns in the very immature fetus can distress parents and caregivers alike. However, knowledge of the fetal response to labor helps the neonatologist make better decisions about how to treat the infant. In addition, ultrasound estimates of gestational age at this time have shown considerable variations. A fetus presumed to be 23 weeks of gestation before birth may be assessed to be 25 weeks or older after birth and suited to more intense treatment than planned, especially if the woman had no prenatal care before entering the hospital. Much of the general nursing care for a woman having preterm labor also applies to women experiencing other types of high risk pregnancies. Women may need multiple hospitalizations that occur in the middle of the night, disrupting sleep and family routines. Other women may have attended a routine prenatal visit and be shocked to discover that they may be in preterm labor. These women often have some activity modifications and may have to stop working if the best outcome for their pregnancy is to be achieved. Therefore, this section focuses on the family's psychosocial concerns, management of home care, and the woman's boredom. Psychosocial concerns. Assessment. The entire family is affected by stressors associated with a high risk pregnancy. Assess how the woman and her family usually cope with crisis situations and how they are coping with this one. Identify their greatest concerns to prioritize care. For example, the nurse might say, "This development in your pregnancy may have been a shock." The following are other questions a nurse might ask. How are you handling things? In what ways do you usually handle crisis situations in your family? What concerns you the most right now? Rather than asking questions in a rapid fire manner, the nurse should give the woman time to answer assessment questions because stress has narrowed her focus. The woman or her family may have physical, emotional, and cognitive impairments because of the unexpected problems. Physical signs of emotional distress, such as tremulousness, palpitations, and restlessness, also are side effects of beta adrenergic drugs and corticosteroids. The woman may express fear, helplessness, or disbelief. She may be irritable and tearful. Her ability to concentrate may be impaired at a time when she needs to absorb new information. Her partner often feels at loose ends. He struggles to keep the household running if she should decrease her activity level. Young children recognize their parents' anxiety and may misbehave or regress. They may feel abandoned if they must be temporarily placed with relatives or friends. The woman may need to stop working, straining family finances. If she does not have sick time or other benefits, the family sustains an abrupt drop in income at a time when medical expenses are mounting. A woman may be transferred to a distant hospital, having a better capacity to care for her and her preterm baby. A distant transfer to a higher level maternity care facility makes it more difficult for the woman to receive support from friends, family, or support groups. Overlaid on the sudden change in lifestyle is the family's concern for their baby's well being. A woman may feel pulled in many directions by the needs of all her children, those already born and the fetus she is trying to mature. She may be concerned about the effects of drug therapy on the fetus and her own body. Identification of patient problems. Unexpected development of complications during pregnancy can prevent a woman and her family from using their normal coping mechanisms. Therefore, the patient problem selected for the woman and family is apprehension due to uncertain outcome of the pregnancy, disruption of relationships with family and friends, and financial concerns. Planning. Expected outcomes. The outcome of any pregnancy is never certain, especially when the pregnancy is a high-risk one. Goals and expected outcomes should focus on the family's ability to cope with the crisis of preterm labor. The appropriate goal is the woman and family will identify one or more constructive methods to cope with this temporary disruption in their lives. Interventions. Providing information. Knowledge decreases anxiety and fear related to the unknown. Include appropriate family members so they are more likely to be supportive. Appropriate family members may include the woman's partner, mother or mother-in-law, adult siblings, and others, but this may vary according to culture. Determine the extent of the woman's knowledge about preterm birth and the specific therapy recommended. Determine what information the parents need about problems that a preterm infant may face. Use this opportunity to correct misinformation and reinforce accurate information. Initially, the woman for whom activity modification is prescribed may be highly motivated. Because contractions often diminish, even if for only a short time, she may become restless. She may think there is now no need for any restriction. Explain what is currently known about the benefits of activity modification for her pregnancy complication, and assure her that recommendations to restrict her activity often lessen as her pregnancy progresses. Initiate consultations from caregivers such as physical, occupational, and recreational therapists, social workers, and other professionals whose services might benefit the woman. The Sidelines National Support Network, www.sidelines.org, is an online network of local groups across the country for women experiencing high-risk pregnancy, including the risk for preterm birth. The site has information for women sidelined by pregnancy complications, including articles, information about reimbursement from insurance, and contact via email with others who have been sidelined. Promoting expression of concerns. Encourage the woman and her family to express their concerns. Begin by exploring common concerns of women with problem pregnancies. For example, most women are worried when they must adjust their work schedules. How has this affected your family? An open-ended question gives the woman and her family a chance to express their feelings so they can take the next step, identifying constructive methods to cope with the situation. Collaboration with a social worker may identify financial or other community resources available. Ask her if she would like a visit from a chaplain. Teaching what may occur during a preterm birth. Because preterm birth often occurs despite all interventions, a pregnant woman and her partner should be prepared for this possibility. If the hospital has a NICU, a nurse often visits the parents to explain what might occur if their baby is born early. One or both parents may tour the unit to see the equipment and care given to preterm infants. In hospitals with NICUs, one or more neonatal nurses, a neonatal nurse practitioner, a neonatologist, or a combination of these are present at birth to care for the infant. The woman who has planned to give birth in a hospital without a NICU may be transferred to a facility with this type of unit before the birth to allow immediate care and stabilization of her newborn. The infant also may be transferred after birth if there is no time to transfer the woman before birth or the infant has more problems than were anticipated. Hospitalization of the mother, infant, or both at a distant location adds to the stress on the family and can impair the attachment process. The expected outcome for this patient problem is achieved if the woman and her family can identify one or more constructive methods to deal with their anxiety. Management of home care. Assessment. Care of women with high-risk pregnancies, including a risk for preterm birth, often occurs in their homes if the gestation is sufficiently advanced and the signs and symptoms of preterm labor and birth have diminished significantly. Many daily household activities are managed by the woman, even if only by her directions to others. However, when labor complication becomes greater, family roles are again disrupted because of the changed relationships among family members. Multiple professionals are likely to be involved in home care, including home care nurses and assistants, social workers, therapists, physical occupational, and others. Clarify the level of activity prescribed by the physician, and identify the role of each member of the household. A good way to do this is to have the woman describe a usual day before any limitations were recommended. Determine the number and ages of children in the home. Evaluate the home itself, either by visual inspection or by questioning the family. Does the home or apartment have more than one level? Determine whether a telephone is available for emergency contact. If the woman works, can she do her work online? Evaluate the family's resources and their willingness to use them. Ask whether family members and friends in the area are available to help. Explore local support groups, such as churches or mother-to-mother networks, that the family might contact for assistance. Determine financial reimbursement that may be available through insurance coverage. Identification of patient problems. Activity limitations for the woman may require adjustment in roles and responsibilities of all members of a family, resulting in possible changes in the home environment because of altered roles and responsibilities. Planning expected outcomes. 2 goals and expected outcomes are appropriate for this patient problem. The short-term goal may change over time if the woman remains pregnant. Short-term goal. The family will identify methods for management of daily household routines. Long-term goal. The woman will be able to maintain the prescribed levels of activity and drug therapy. Interventions. The pregnancy threatened by preterm labor or other complications that require activity modification is a self-limiting situation, making temporary adjustments somewhat easier.